I have the honor to introduce some of the research panel speakers today. I'm assuming we're going in the order on the screen here. Okay, so it's not necessarily in the order they're sitting. So first up is Tara DeSilva. She is faculty at University of Alabama. And can I tell them where you're going soon? Moving? Not yet. Okay. Who works on neuroimmune diseases in the lab. She's a basic scientist, and she's going to show us a little bit of research in her lab.
Thank you. So today I'd like to talk to you about two aspects that we're working on in the lab, and that is how do we block immune cell infiltration into the spinal cord. In particular, we're looking at disease models that are similar to TM. They're not exact representations of the human disease. No animal models really represent the human disease, but we can understand a lot about the underlying mechanisms of how this works and then how to target this for pharmacological interventions. And number two, how can we prevent CNS damage? This is particularly important for axonal injury, because once we have axonal injury, we have permanent paralysis and loss of motor function. So as we move along here, I can change the slide here. We're very interested in the role of glutamate, and many of you may know glutamate is a very important neurotransmitter in the brain, and it has important normal physiological conditions, everything from walking to thinking to moving. However, when you have too much glutamate, you can have damage, particularly excitotoxic damage, to neurons as well as oligodendrocytes, which are the cells that comprise the myelin sheath. So we're very interested in how inflammation can elicit these excitotoxic mechanisms and if they're playing an important role in this disease. And so we became very interested in the system XC transporter as a potential source of this excitotoxic glutamate and contributing to the excitotoxic pool, meaning that that might be a better way to target or protect cells versus blocking the receptors that are very important for normal physiological processes. Is there a way we can block the source as a better way to improve this disease? And so what we did and started off with our animal models is introduce pharmacological inhibitors of the system XC transporter. And as you can see here, this is our animal model of the disease. And the higher the score, the more motor impairments these animals have. The lower the score, the better the outcomes are on these animals. And in this lower line here, I hope you can appreciate, this is the animals that receive pharmacological inhibitors of the system XC transporter. These animals are doing much better. And then if we take a look at our spinal cord sections, quickly, this is just myelin is blue on the outside. That's our white matter. And we can see that this white matter is protected from demyelination. And then we back up all of our experiments with genetic animals because there are off-target effects that pharmacology can incur, and we want to make sure that this system XC transporter is actually playing a role. And again, here is our genetic animals where we've genetically deleted the system XC transporter. These animals do quite well. They're more resistant to the disease than animals that do not, we have not genetically deleted the transporter. And then interestingly, we also wanted to make sure that this protection that we're seeing here is actually due to CNS protection, where we're actually blocking the cells from dying, or we've actually inhibited the immune cells from getting in. Because again, if we inhibit the immune cells from getting into the spinal cord, that will also show protection. And indeed, we did show here that our immune cells, in particular T cells, are being reduced or not getting into the spinal cord region, which was unexpected, suggesting a novel role for glutamate in regulating immune cell infiltration. So in order to still look at this CNS damage and understand whether or not we are still protecting these cells from dying, we altered our model a little. Now we're allowing the relapse to happen. We're allowing all the immune cells to get into the spinal cord, and then introducing our drug intervention and seeing what's happening here to the myelin. And again, what we are seeing is that upon pharmacological intervention, later in the disease, after the immune cells have gotten in, and we think the glutamate and its excitotoxic mechanisms are about to happen, we see protection here in these animals with the pharmacological intervention. And then what we do in the lab to better understand mechanism is we can take these cells, we can culture them, we can culture immune cells with reactive glial cells as well as the oligodendrocytes that make up the myelin sheath, and really study on a molecular level what's happening here. And indeed what we're seeing is that if we recapitulate this neuroinflammatory environment that we have in the spinal cord, that we can cause an increase of glutamate here, and that we can block that with the system XC transporter. And indeed, if we do the same pharmacology where we're inhibiting the system XC transporters, we can selectively block oligodendrocyte death from happening, suggesting that this new pharmacological target that we're interested in is not only important for immune cell infiltration, but as many of you know, a lot of times patients presenting in the clinic may already have had the insult or the neuroinflammatory insult into their spinal cord, suggesting that this drug intervention can be important for CNS protection after the immune cell infiltration has occurred. Thank you.
So you'll get a chance to ask Dr. DeSilva questions. What she didn't tell you at the beginning is that it's this type of research that leads to trials that you're going to hear about now. First from RoisIn, who is from Alexion Pharmaceuticals. They have a trial of their drug eculizumab that is launched last year for the treatment of NMO. So RoisIn. There's forward, backwards.
Forward, backwards. Okay, thank you so much. Good morning, everybody. So over the next few moments, I will try and take you on a kind of a whistle-stop tour, or just an overview of the ongoing phase 3 trial of eculizumab, which is otherwise referred to as the PREVENT study, as the slide shows, in Neuromyelitis Optica. So we were asked to share our disclosures. So as Mike commented, full-time Alexion colleague. And then really moving into the PREVENT study. So this is a study, as Mike mentioned there, we launched just in 2014 in relapsing NMO. And the goal of the study is to evaluate whether a drug called eculizumab can prevent the relapses that occur associated with NMO. Now, a little bit about eculizumab in of itself. It's a biologic, it's a monoclonal antibody, and it's targeted towards the immune system. And by way of its mechanism of action and targeting the immune system, the study is evaluating its ability to prevent the disease relapses. It is an investigational agent in NMO. It's not an approved agent. It has been approved in 2 other rare diseases in some countries. And really the purpose of the PREVENT trial as a phase 3, what we call a phase 3 registration trial, is really to evaluate in the criteria that would be expected of the regulators and the standards as to whether or not if the data should be positive, it actually can be brought forward as a new medicine in the treatment of relapsing NMO. So in terms of mechanism of action, at a very high level, eculizumab very specifically targets what's known as the complement system and part of the immune system, and associated with implication in the etiology or the cause of the disease relapses. And as I'll come on to in just when I describe the trial in I think in the next slide actually, it's this, you heard Dr. Levy just speak earlier before the break in his presentation around the role of the antibody, the NMO IgG antibody, or otherwise known as the AQP4, the water channel antibody. But that's a factor in the eculizumab program when we identify patients. But it's this interaction of the antibody with water channels triggering the inflammatory response. And so the mechanism of action of eculizumab is to inhibit when the antibody interacts with the water channel, complement is activated, that causes the damage, and eculizumab is a blocker of complement. Okay, so quickly moving into the study, because I know we'll have Q&A afterwards. But to be eligible to participate in this ongoing study, it's aged 18 and over with a diagnosis of NMO or NMOSD, and also with a positive blood test as confirmed actually by the Mayo Clinic at the beginning of the study for this antibody, the NMO-IgG or AQP4 antibody. It kind of goes by both names. And also, it's for those patients who have been experiencing frequent relapses. And that's been characterized in our study protocol as at least 2 relapses in the past 12 months, or at least 3 in the past 24 months, provided one of those 3 occurs in the past 12 months. There are some exclusion criteria, and if you just look at the gray panel on the right-hand side, you would not be able to participate in the study if you have been taking rituximab recently, and that's defined as within 3 months, or another immunosuppressive therapy called mitoxantrone, or alternatively IVIG within the past 3 weeks. And what I haven't touched on actually is the study does permit, if you're taking a current immunosuppressive therapy for your NMO, other than rituximab or mitoxantrone within those time windows, but you can continue on that medication. So you may have heard of the terminology an add-on study. So this is what's referred to as an add-on study. You can enter into the trial still taking your existing NMO treatment. And then if you're eligible to participate, what can be expected? Well, the randomization, and again in this prospectively designed trial, is for every 3 patients that are randomized, 2 will be randomized to the active medication, eculizumab, and 1 will be, the 3rd patient will be randomized to placebo. That's what we mean by the 2 to 1 randomization. The mode of administration of eculizumab is through an intravenous infusion, and it's administered every 2 weeks. It's also a blinded study, and again that goes back to my opening remark about a phase 3 registrational trial, when we're really designing our trials to the adequate caliber and standards that we all expect, frankly, when medicines are approved. And so it's a blind trial, meaning your doctor, the nursing staff, the study coordinators, those of us in the company as well, we will not know who is receiving active medication or placebo during the conduct of the trial. And then this is the final slide, and it really is to capture then that when the phase 3 trial completes, patients will have the opportunity to enter into an open label extension trial in which all patients will receive eculizumab. And that was very brief, a little sort of summary. So by way of backup, please ask questions during the Q&A, and hopefully I'll be able to clarify anything that was a little bit confusing. And failing that, we'll have some brochures which are sitting outside on the registration desk. Again, if you don't get an opportunity or you haven't got questions at the time, even just to lift one of these up, it gives the website, and you may find just some useful information. Thank you.
Thanks, RoisIn. So Alexion was the first to launch their trial in the very small field of patients, 8,000 maybe in the US. We have 3 of these registrational trials, which I think points to the fact that good research leads to good trials. I like to think that that's what it was. So next up, you'll hear from Angela Melia about another drug from Chugai, which is based in Japan. They're a subsidiary of Roche, and they have a drug which they've also launched into a phase 3 trial. So please.
Thank you, Dr. Lee. On behalf of Chugai, I would just like to thank Chitra and the TMA and all of you for inviting me to be here today to speak to you about this trial. I think you've heard a theme already this morning from Dr. Levy and from RoisIn that one of the key features of NMO is the presence of NMO-IgG, or anti-aquaporin 4 antibody. There is a professor in Japan named Professor Yamamura and his co-workers that have identified a particular subset of B cells, the B cells plasmablasts, that produce this anti-aquaporin 4 antibody. There's also a substance we have in our bodies called interleukin-6, or IL-6. IL-6 stimulates the growth and the production of these B cells. So you can see that if we could find a way to block the activity of IL-6, we can hamper the growth of these B cells, thereby decreasing the levels of this anti-aquaporin 4 antibody. And that's just a little bit about the rationale of what the Socorro STAR study is about. And I will get into that now. So as RoisIn pointed out for the PREVENT trial for Alexion, we also have key inclusion and exclusion criteria, which are common to any clinical trial. For this particular trial, some of the key criteria are you must be either NMO-IgG positive, or if you're diagnosed with NMOSD, you must be NMO is NMO positive or negative, but if you're NMOSD, you must be NMO-IgG positive. The age range is 18 to 74 years old, and you must have had one documented relapse within the past 12 months. Some of the exclusion criteria is pregnancy or lactation, evidence of any other demyelinating disease, or a known active infection, excluding fungal infections or dental cavities within 4 weeks prior to baseline. So I think everybody in this room has probably heard of David Letterman and his top 10 list. So what I've done is we put together a list of reasons on why a patient would even consider to want to be in a clinical trial, in particular this clinical trial. So reason number one is SA237, which is the investigational compound we are researching. It's a novel, unique compound to be used for NMO, and it's based on some anecdotal data that we have that shows a reduction in the relapse rate and improvement in pain with patients with refractory disease. As I mentioned, IL-6 inhibitory therapy is widely used in RA, or rheumatoid arthritis, juvenile idiopathic arthritis, and Castleman's disease, and has been shown to be well tolerated in those diseases. We've had a very good safety profile that was demonstrated to date in our phase 1 studies. As Alexion had a 3-to-1 ratio, we have a 2-to-1 active drug to placebo ratio, which means you have twice the chance to receive SA237 as you do the placebo. Our route of administration of SA237 is a subcutaneous injection. And it's every 4 weeks. The nature of SA237 is that it's a recycling monoclonal antibody. So when SA237 attaches to the IL-6 receptor on the cell surface, it gets taken inside the cell, where typically it would get broken down and dissociated. However, when SA237 is brought inside the cell with the IL-6 complex, it releases the complex and is recirculated to the surface where it can be used again. So that's the recycling nature. And it's because of that recycling that you only need to be dosed every 4 weeks rather than more frequent. And it's not an infusion. Like I said, it's just a sub-Q injection, which is superficially under your skin. In this trial, we will carefully monitor your safety. There are weekly phone calls from the site to patients just to check in and see how you're doing, so that we could potentially pick up on the slightest signs of a relapse. All expenses related to the study visits, both for the patient and if the patient has a caregiver, will be reimbursed. And these are things like you see here: meals, transportation, if you have to stay overnight in a hotel, things like that. We are also offering a 1-year open-label extension of SA237 free of charge to patients who complete the trial. and we're now amending the protocol to provide that drug until commercial authorization. So we are in communication with the FDA to extend the trial. Thank you very much.
Thank you, Angela. There's a third trial that has launched in the phase 3 program called MedImmune. The drug is Medi-551. MedImmune is based in Maryland, where I am, and Ellie is here to describe his program, which again is the third study out of 3 that's in phase 3 trials now. Forwards, backwards.
Thank you so much. I would like to thank Chitra to invite me, and I would like to thank Ben Greenberg for giving me the instruction how to get to this country of Dallas. As you hear from my accent, I feel a little bit foreigner anywhere I'm going in the US, but in Dallas especially, although I spent some years of my clinical career in Oklahoma, which is not far from here, so I got a little bit used to that. And I have cowboy boots also. For me, I must tell you, spending many years of my life as a clinician, since I moved to industry, I always remind myself every day that it's all about patients. And to come to these meetings, and this is not the first one, in different area of disease area, and to see you, the patients, and to see what actually we're dealing with, and why it's so important to do what we're doing. I think it's really a very significant thing, and I think I always welcome the opportunity to be in this type of meetings. I'm going to describe to you shortly what we're doing in MedImmune. We're running a study that we called NMOMentum. As you can see from the logo and the way it's written, there was a lot of creativity in that. We actually ran a competition in the company who come with the most, attractive kind of thing, and I think it's so we have the NMO inside, and we have this thing, and it's really. So you heard today quite a bit about the background of NMO and the central role of the antibody, the aquaporin 4 antibody that probably plays a role in the disease. Now, as you may know, we are producing antibodies, different kind and many antibodies, each one of us every day for different reasons. And the main aim of these antibodies is part of the immune system to fight usually infections, different type of infection and different things. Now, many of the autoimmune diseases that we dealing with are where our immune system is kind of losing its direction, many people in Dallas, and instead of protecting us against different things, start to attack our own body. So NMO is one of those diseases probably where the immune system, for whatever reason, losing its direction and start to create antibodies against our own nervous system. And in this regard, you heard is the water channels in these astrocytes. And this caused the damage. Now, who is producing all these antibodies? These are one type of cells that group under the lymphocytes, which we have all of us in our blood. We have B cells, and we have T cells, and we have other cells. So, but the B cells are really important here, but because the B cell has this unique capability, when they recognize a trigger like bacterial infection or viral infection or something in our tissue that trigger them, they go through a process which end up with what you heard before is the plasmablast or the plasma cells, that you can think about them as a very sophisticated factories that actually produce the antibodies. And it became a very specialized, what we call clone of B cells, that's what they're doing, just producing these antibodies, and you get these antibodies coming to the blood and do what they do, and in NMO, it's probably causing the damage that we're realizing in the disease. So the drug that MedImmune developed is actually going after these B cells. In other words, we are under the category of what it's called a depleting agent, which means we're going after the B cells and eliminate them. And I'll show you evidence for that. So our drug is connecting to B cells and then by this connection, cause them to actually be killed and be eliminated from the circulation. So you can understand if you eliminate the factories, then there is no production of the antibody, and probably this will, result in prevention of attacks and overall better long-term prognosis for the patient. All of this needs to be proven, although we have some proof about the importance of B cells in this disease and elimination of them. I don't know if you heard, probably some of you heard the name of the drug rituximab, which is similar in its mechanism of action, and we already have some indication that it may have a positive effect in NMO and other diseases. So this is a pointer, right? Whoop. Here. So what we have here is, again, it's called monoclonal antibodies. So we produce this antibody that recognize a specific antigen. Antigen is a molecule, is a protein on the surface of the B cells, which is called CD19. There are many of those, but one of them called CD19. It's specific for B cells. So our drug, which is an antibody, connected to this CD19 antigen, and on the other side, it has a very good connection to two important cells, the macrophage and the NK cell. The NK is K comes from killer. So we recruited two types of cells that actually causing the B cell to be, where is the X that shows the B cell is going to die? Here. So that's kind of what happened in a very schematic presentation. You see here the B cells squeezed between these two cells, and here is the antibody that connect all this together, and this create a mechanism of killing, and the B cell is being eliminated. So this is the basic of the principle of this drug and how it works. So here is, as I said before, you see here the way that the B cell, from the very early cell that started in the bone marrow usually, how it developed into mature B cells, and how it here developed, it's what we call plasmablast and then plasma cells. And you can see with this antibody kind of schematic showing to you that these are the factories that I talked before that producing the antibody. And this is the plasmablast that my friend from Chugai mentioned as the cell that was also identified as producing the antibodies in this regard. Now, what we're showing here, that this protein, which is the antigen on the surface of the cell, which we call CD19, is actually presented in almost all B cells, including the plasmablast and the plasma cells. And this is a little bit different. For example, rituximab, which is the CD20 protein that we go after, which is not presented so well on the plasmablast and plasma cells. So there is a theoretical advantage here that needs to be proven, not proven yet, that by the CD19 taking, with our drug, taking the CD19 and taking out these cells, probably we're going to see maybe faster or maybe more pronounced effect. So this is the idea. Come on. What I want to show now, just a few slides that shows you how it works. So I'm sure you can hear me without the microphone, right? I never was accused of not being heard. So here, what you see is the different doses of our drug in a study that we did, a phase 1 in scleroderma. And what you see here, that this is the placebo, and we're measuring here the B cells, and you see that after one dose of the drug, in a different doses, We're being recorded. Oh my God.
Nobody can hear.
I wasn't warned about that before. I hope it's there so far. Okay. So what you see here, this is a placebo, and the B cells remain kind of in the range of normal. And you see after each dose, there is a different length of time. This is the study visit, but days, that the B cells going very low, below what we're seeing is the 10% for normal, and remain like that, until they start to come up. So this drug actually given IV, it's an IV infusion, but it's given once in 6 months in the dose we're now testing. So you're giving one dose, and the B cells go down and remain very low with this dose for 6 months. And the next dose is after 6 months. So this is kind of what we're showing here. This is another study which shows you the same, which is early MS, phase 1 in MS patient. This is the placebo, and here you see how the cells are going down and remain down, depends on the dose that you're giving. The other thing we like to show you is something that MedImmune developed, which is kind of fun, We developed what we call plasma cell gene signature. So we look at the cells, and it's something that's being used today in a lot of research and clinical studies. We learn how to use genes for different purposes. One of them is actually to identify you. So I can take a certain cell, and I can identify the cell by specific genes that these cells is, present more than other cells. So we took a bunch of plasma cell gene, and we said this is the way we're going to recognize plasma cells, which are the factories for these antibodies, in the blood. And what you see here, this is placebo, the orange one, and then in different doses to 551, you see actually significant decrease in the plasma cell signature. So this is a direct way to show that the drug is actually working well and lowering the level of those cells that we want to lower in order to have an effect. So I'm not going to go in more details about, I think this is my last slide. Yes, about the study itself. I mean, the principle of what you heard from my friends in Chugai and Alexion is quite similar to what we're doing. Details of this, you can talk to your physician. All of them, I'm sure, know about the study. Anyone wants more details about actually the study and inclusion, exclusion, lengths of the study, placebo versus the treatment, I'm here. I'll be happy to answer any question you may have. Thank you.
This is quite an immunology lesson. Not sure if you guys are taking notes, but there will be a test at the end of this. You have to know what a B cell is when you leave here. Next up, we have Don Healey. He is from Texas, from Houston, Woodlands area.
From the UK originally.
From the UK originally, but I think, are you a Texans fan now?
Getting there.
Okay. And he's working on a very different approach to the treatment of NMO.
Good morning, everyone. Thanks for the opportunity to come and speak with you today. So the first slide up here is sort of a summary, if you like, of the key players that are involved in the induction of the autoimmune condition Neuromyelitis Optica. We've heard a lot already about the role of B cells and the production of the autoantibody, in particular its ability to target aquaporin-4 and astrocytes, which results ultimately in the neurodegenerative event. Autoantibodies are associated with B cells per se. We've heard that targeting therapies to the B cell compartment are being investigated. The antibody response is associated with fixing of complement, so also targeting complement is also being investigated in late-stage trials. But our approach at Opexa is to sort of look a little bit more outside of the box and say that there are other cell populations that are also active in the neurodegenerative process. And in particular, on the right-hand side here, you can see there are inflammatory cells that get recruited into the target lesion that can amplify the neurodegenerative event. Now, both B cells and this cellular infiltration can't work in isolation. They actually need help. And the population of cells that provide that help we refer to as T cells. And not surprisingly, these are called helper T cells. And so we believe that there is a subset of T cells that are also responding to the same target antigen, aquaporin-4, that provides help for antibody production and is also responsible for the recruitment of inflammatory cells to the target tissue. So as opposed to looking at the autoantibody response or maybe the cellular infiltration, if you're able to take out the which one's? There we go. If you're able to take out the pathogenic T cells selectively, would you then be able to result in a positive benefit in terms of impeding autoantibody B cell function and also blocking cellular infiltration? So we like to think of the T cell as being like the conductor of the orchestra. If you can take that conductor away, the peripheral elements that are dependent upon it will also then wane and their function will diminish. As a consequence, you'd hope to see positive clinical benefit. So there are indeed a number of entities or cytotoxic drugs, for instance, that can take out T cells at a global level. Would you expect them to have some efficacy? Probably. Is that a wise choice for an autoimmune condition to actually take out large chunks of your T cell repertoire? Remember, your T cells also provide help for fighting infections, for combating cancer. So if you take away all your T cells, your neurodegeneration may improve, but now you're globally suppressed and prone to infections. So there's always this payoff between efficacy and safety. So what would be really neat is if there was a selective way just to target those pathogenic T cells, those disease-causing T cells responsible for your NMO, but leave all your other T cells that respond to cancer infections fully intact. Strategic, targeted, focused therapeutic on those T cells causing damage. So the strategy we take at Opexa is to say, well, you know, the immune response essentially caused this problem. Can we use the immune response to put it right? Can we actually target the immune response onto those pathogenic T cells in a selective manner? So just as immunity is able to detect a virus, a bacteria, or a cancer cell, can we get the immune response to actually selectively target this disease-causing entity, this aquaporin-4 reactive T cell itself? So in essence, we take a similar strategy as you would do for an infectious agent. You build a vaccine. So in our particular case, this is an autologous T cell vaccine. We identify the T cell that's causing damage in you from a peripheral blood sample. So we're going to use your own cells to treat you. We bulk up those pathogenic T cells in a manufacturing process, then reintroduce them back into the body in attenuated form. So they're inactive, but nevertheless capable of invoking immunity. So we're going to vaccinate you against the very same cells that are causing your autoimmune condition in you as an individual. Tailored, personalized products for each individual patient. So a highly strategic, focused therapeutic strategy. So in a nutshell, here's the sort of profile in terms of the manufacturing process itself. Up front, we start with a blood sample. We want to be able to detect the presence of those pathogenic T cells, that disease-causing element in your peripheral blood. So we do that by incubating a sample of your blood with the target protein itself, aquaporin-4, or actually we use peptides, which are fragments of aquaporin-4. And if we can detect the presence of that pathogenic T cell in the peripheral blood, we know we're able to then to make a product for you. So we take another sample of blood, a larger aliquot this time, and then actually physically grow out those pathogenic T cells that we think is associated with causing your disease. So we bulk them up in a manufacturing process. The purpose for the bulking up is to provide sufficient numbers of cells to actually use as the vaccine itself. So there are a number of doses that have to be administered to the patient, just like a conventional vaccine. So this one manufacturing cycle generates all the dosing requirements we need for that individual patient for that particular year. And in particular, each patient will receive 5 doses over the course of the first 6 months in a 12-month period. And then essentially a drug holiday for the second 6 months of that 12-month period. Remember, this is a vaccine-type strategy, so you dose, boost, and there should be a legacy effect reflecting the capacity of the immune response then to provide the surveillance over an elongated period of time, therefore giving you the protection itself against your neurologic disease. So moving on to the last slide. We're currently in our sort of preclinical phase, so we're putting together our IND submission to be open a phase 1/2 clinical study in 2016. It'll probably be open label in design. Obviously, the primary endpoints tend to be associated with safety, and we'll have some biomarker components we'll roll into that design. It'll be a dose escalation, so we're going to look at the number of cells you have to administer to a patient to see a positive benefit, at least at the level of a biomarker. Looking also at multiple doses, so not only number of cells injected, but how often you have to inject that product to see a positive clinical benefit. And obviously, safety, as we've already mentioned, will be closely monitored throughout the study. So ultimately, we hope to initiate this program with FDA review of our IND in the early half of 2016. So I'll leave you there. Thank you.